listening to the Pharmacy Podcast Network.
You're listening to Framework Focus, the podcast that explores trends, innovations, and insights in the long-term care pharmacy industry. Join us as we connect the entire LTC ecosystem.
Hey, welcome back to Framework Focus. This is the podcast for everything long-term care pharmacy by SoftWriters. And it's interesting. They've been a partner of the Pharmacy Podcast Network for several years. It's where I started my entire pharmacy career at SoftWriters many, many moons ago, 2004. Goodness gracious, it's making me feel old. And I have another, I don't want to call you old, Dae, but I have another veteran of pharmacy here with us today, talking about policy and things impacting long-term care pharmacy. It's so good to see you, Dae. How are you?
Good. Thanks for having me today.
You're very welcome. Dr. Dae Lee is a PharmD. You're a lawyer. You have a deep understanding of what's happening in different sectors of pharmacy. Today, we're concentrating on the impact of several things happening in these United States that is going to trickle down, is going to impact long-term care pharmacy. And the regulatory updates for long-term care pharmacy, they always seem like they're shifting, they're changing, depending what's happening at the state level, federal level. We understand things are changing for maximum fair pricing and in the Inflation Reduction Act. What I'm going to do, Dae, for our listeners is I'd like it to turn it over to you. I'd like you to give just a brief introduction of yourself and what firm that you're with and what you do out there in pharmacy. And then we're going to dig deep into some of these questions impacting our long-term care pharmacy operators.
Thank you. Again, my name is Dae Lee. I'm a shareholder, pharmacist attorney at Buchanan Ingalls Rooney. My office is in Jersey and New York, but I think we have about 17 or 18 offices throughout the country with almost 500 attorneys and the government professionals. My main practice is pharmacy. I represent a lot of independent pharmacies, different types, whether it be retail, long-term care, mail order, specialty, whether it be true mom and pop or private equity backed. I also represent plan sponsors and employers in their dealings against, top 3 or top 6 pharmacy benefit managers. And of course, I do have different clientele aside of those, including manufacturers and wholesalers. So I pretty much touch upon every single topic involving pharmacy.
Dae, thanks for setting the stage for us. It really helps if someone's driving, if they're walking their dog and they're listening in. We always like to get an understanding of the insights and who it's coming from, and what a better person to have as we talk about maximum fair pricing, which is known as MFP, what's happening with the national playing field for long-term care pharmacy and the IRA Medicare drug price negotiations. Would you give us just an opening and a stage set so that we can ask some more specific questions about what's happening in reimbursement?
Sure. A lot of, not limited to long-term care, but right now, pharmacy industry is filled with a lot of developments, right? Positive developments, because for the past years, several years, or even a decade, pharmacy benefit managers, especially the top 3, CVS Caremark, United, Optum Rx, and Cigna Express Scripts, have been really, unfair treatment towards independent pharmacies. And they actually have, in my opinion, they have double standard because, as you know, they are vertically integrated. They have their own pharmacies and they have their own providers, and they look kindly upon their own versus, non-affiliated or non-PBM owned pharmacies. So there has been a lot of positive development because more people have been getting educated. More legislators are trying to make the playing field leveled and fair for the independent pharmacies out there. So, in the Inflation Reduction Act, maximum fair price, those are, some of the items or developments that, brought positive impact on the pharmacy industry. So when people hear Inflation Reduction Act, IRA, they think sometimes they think political talking point, right? But what it actually did in healthcare is fundamentally restructure the Medicare Part D economics. And I think there are three pieces that long-term care pharmacies need to understand regarding the IRA. The first one is Medicare is now negotiating prices for a certain high-cost drug. That is a drug pricing negotiation program. Second thing is, I believe starting in 2025, the Medicare Part D, as in David, their benefit design shifted shifted into putting much more financial liability onto the plans in the catastrophic phase. And the third one is the beneficiary now have, I want to say, $2,000 annual out-of-pocket cap. So sounds patient-friendly, and in many ways it is. But every time, Washington reduces beneficiary exposure, someone else absorbs the cost. Mm-hmm. And in this case, it's primarily Part D plans and the manufacturers. And when plans absorb more liability, they're going to respond, right? They're going to tighten the contract, they're going to tighten the reimbursement, and possibly the utilization of it. And that's when the long-term care pharmacies, they may start to feel pressure. Now, moving on to the maximum fair price, MFP, under the IRA, CMS selects certain high-cost single-source drug without generic competition and negotiates something called maximum fair price, MFP. I want to say the first 10 drugs took effect in 2016, and the more drugs is going to gonna roll in the subsequent years. And MFP is essentially a government set ceiling price for Medicare. Now, manufacturers must offer those prices to pharmacies, dispensing to Medicare beneficiaries. So MFP governs the ingredient cost, and it's gonna have an impact, right? It's gonna have an impact on not only the dispensing pharmacies but also the plans, because if you think about it, these plans or plan sponsors are used to getting rebate checks, right? And the rebate checks, as you may know, the top three PBMs, or at least two of them, OptumRx and Express Scripts, have already come out and said that in response to all these pressures, legislative pressure that they're feeling, and the public outcry that, hey, we're going to move away from the rebate, back-end rebate, and we're going to apply on the front end. It's going to reduce the ingredient cost, okay? Sort of like MFP does. Mm-hmm. Now, how are they going to capture that? I don't know. They haven't really provided any clarification on or laid out groundwork or showed methodology on how the back-end rebates is going to be applied on the front end, and how it's going to impact the total drug spend of the plan sponsors and the out-of-pocket cost of the patient. Mm-hmm. They didn't really get into it. It was more of a, I want to say, reactive response by the PBMs to the a lot of legislative pressure and the public outcry.
Yeah, I remember and it's been like a jigsaw puzzle with different things happening, not only from the state perspective, that then some of the data and outcomes of different state legislation for PBM reform then impacts other states, and then that rolls up to our federal. We know that Texas State Representative Beth Van Duyn and her team, and this is nice because it's bipartisan representatives from the state of Illinois, Democrats, Republicans from Georgia, Buddy Carter, shout out to that guy. He's just amazing. They're all working on HR 5031, which is the Preserving Patient Access to Long-Term Care Pharmacies Act. And that, of course, overlays everything else that's happening with these other things that, like I said, Dae, it's very confusing to follow how it fits like a jigsaw puzzle. But can you kind of give some of your insights to how that might play into a resolution where we're not going to lose long-term care pharmacies moving forward?
Sure. I mean, I don't think we're going to lose long-term care pharmacies in the future.
Okay.
As you may know, there are states that are trying to prohibit PBMs to own their own pharmacies, such as Arkansas. And then I believe very recently, it could have been as recent as yesterday, that Tennessee actually passed a law or introduced a bill trying to follow the Arkansas footsteps.
Mhm.
Okay. So, and plus, chain pharmacies are closing, right? And there will be a lot of influx into the independent pharmacy, whether it be retail or long-term care. Okay. And all these, legislative pressure and a lot of plan sponsor getting educated, that's going to bring positive impact on non-PBM owned pharmacies. But at the same time, what we got to really, watch out for is PBMs. They're vertically integrated. Their parent companies are listed as public companies. They have their stock and a share value, right? They're gonna have to make up some of the lost revenue from somewhere else, and I feel like that's gonna be from the non-PBM owned independent pharmacies, whether it be retail or mail order or even long-term care. So we have to be vigilant in terms of pushing back on any egregious practices that are going to be deployed by those PBMs.
Dae, what impact have we seen? It's now we're moving into the end of the first quarter of 2026, soon to be second quarter, and the senior care pharmacies it is is studying this stuff, and we of course pay attention to SCPC and what they're doing, but they posted something about HR 5031 and also 3159, preserve patient access to long-term care pharmacies. And they were going through some of the issues, and they said that when the negotiated price took effect on January 1st of 2026, long-term care pharmacies will face on they use the word unsustainable revenue loss on brand name medications that are included under the Medicare Part D price negotiation program. So, and I know that there's lots of there's lots of hearsay, meaning there's people that are very intelligent that have data and they try to project what might happen. But what has happened in this first quarter of 2026 in some of the changes that were made on January 1st of 2026?
Lost revenue, the reduced reimbursement. Look, pharmacies, non-PBM owned pharmacies, in order for them to make profit, you have to buy the drugs at a certain price and then sell the drugs at a certain cost or price, right? So that's the delta. Acquisition cost is already there. It's not going to drastically change. What drastically changed thus far is the reimbursement rate. Reimbursement rate went down. So the delta is shrinking, or even delta is into negatives. That's 100% true for non-PBM owned pharmacies, whether it be retail or long-term care pharmacies. And I personally, I'm not a big proponent of government pricing negotiation.
Mhm.
And those brand drugs. Let's say the price goes down, but that doesn't mean that the cost of buying the drugs are going down from the pharmacies from pharmacies' perspective. So the delta is shrinking, is into the negatives, and and plus on top of that, what I've seen in first quarter is a lot of audit activity.
Hmm.
Okay, a lot of audit activity on the pharmacies, and those audit activities require the audits by the PBMs require response, right? And it's going to take away a pharmacy provider's not only time, their staff, but also money, because they're going to lose time to treat the patient. They're going to lose staff time to treat the patient. They're going to have to defend any egregious or unwarranted audit findings. And at the same time, let's say there's an audit finding, just throwing out a number here, 100,000. Okay. And PBMs can start withholding the money or to start withholding the payments submitted that should have been paid on the most recent claim submitted by the pharmacies, even when the audit dispute resolution procedure has not been exhausted. So the pharmacy is going to feel the financial strain until the audit is resolved.
Is the $30, it says the bill addresses the LTC pharmacy fix by creating a temporary, I don't like that word, temporary $30 supplemental supply fee for prescriptions subject to Medicare negotiated price, the MFP, in 2026. And then they say, and 2027, which I'm just like this is just going to carry on. But is that $30? Is that a Band-Aid?
Not even a Band-Aid, but we could call it as a Band-Aid.
That's not cool.
No, not cool at all. And when a lot of times when pharmacies fill brand drugs claims, they lose a lot more than $30.
Yeah.
Some lose hundreds, 200s, or even 300s.
Yep. Yeah. The excitement of different sectors of pharmacy is knowing that they will thrive and they will have a different way of being reimbursed. And long-term care always seemed like it was more insulated than the retail side of things. And now that's just not the case, especially with the plate tectonics of how pharmacies will be and pharmacists will be reimbursed for more of their services and insights in the future. So if you're a pharmacy owner, Dae, and I guess it depends on which state you're in, but if you serve multiple states, for example, what do you encourage these owners and operators to do when it comes to helping their own state and then thus the nation come up with something that is sustainable in the laws? Are you pro like reaching out to state representatives to educate them what's going on because of how confusing this all is? What steps would you take as a pharmacy owner?
Be involved in your state legislation. Be very involved. And if there's a comment opportunity, make sure you submit a comment. Otherwise, PCMA, the lobbying group for the PBM, they're going to submit comments detrimental to your position, to the pharmacist's position. And continue to push forward, continue to educate legislators, patients, and everybody else. And then also maintain records, because pharmacies will be audited, and be forceful when responding to those audits.
The audits are always it's almost like riding a roller coaster, and then you find out through the mail or something that you're going to be audited, and being prepared for that is so key. There's probably something in your policy and procedures manuals to prepare you for such audits. Is that also tied back to star ratings and how you're impacting the overall plan?
Ultimately, yes.
Okay.
But pharmacies will feel the financial strain first when PBMs start withholding money, recouping money, and then, based on those findings, PBMs are going to impose additional sanctions, network interruption, suspension, or termination. But I want to end this or end my comment with a positive tone, which is a lot of good things are happening right now in the pharmacy industry in general for the non-PBM owned or affiliated pharmacies. Let's call it independent pharmacies. A lot of good things happening. We just need to keep the momentum and shift the momentum or refine the momentum to the right direction that actually helps the industry and the patients.
Exactly. All right. If you're listening, you may not be watching on YouTube or some of our social media. If you're just listening in your car driving, you want to know the SCPC has a ton of information. If you can go to seniorcarepharmacies.org, and I'll have a link in the show notes for that. And then also reach out to Dr. Dae Lee. He's active on LinkedIn. His information, I'll make sure that we have a link to LinkedIn for you to reach out today if you have questions, if you'd like to do something with Buchanan and team up with them to get insights and get a pathway. Please definitely reach out to Dae. Every time I talk with you, Dae, I feel like I'm empowered to understand things based on the information that's out there. And with all those puzzle pieces on the table of what is the business and ecosystem of pharmacy, you start to really make sense of it. So we always appreciate you.
I appreciate the opportunity. Thank you.
Hey, you were listening to another episode of Framework Focus, podcast for everything long-term care pharmacy. Take a look. frameworkltc.com/podcast. Once again, that's frameworkltc.com. Reach out to that team and ask questions. If you have any questions about your specific state's legislation and how it will impact your long-term care pharmacy, they have resources to help you with those. And like I said, Dae and his team are also available. And we thank you for listening to Framework Focus.